in ICU patients, simple methods to save patients from exposure keratitis. Neglected eye care in ICUs. Is it a real problem? Yes, definitely. The fate of these patients' eyes, if not taken care of during their ICU stay, though they recover from critical illness, can end up in long-lasting and permanent visual disturbances. ICUs cater to the patients with the most serious problems. These are the various eye protective barriers in healthy individuals. These eye protective barriers get disrupted in ICU patients because of their altered level of consciousness, which results in altered blinking reflex and inadequate lid closure aggravated by mechanical ventilation. The potential eye problems in ICU patients range from conjunctivitis to exposure keratitis to corneal ulceration. Unfortunately, anticipating and preventing eye problems in ICU patients is not a common practice. The aim of our study is to determine the ocular surface abnormalities in ICU patients, to identify the factors predisposing to them, and to propose an effective method for preventive eye care in ICUs. This is a prospective, non-randomized study. The study protocol was cleared by the Ethics Committee of the institution. The study was done over 1.5 years on 200 consecutive patients admitted to the various faculties of Karnool Medical College, Karnool. All patients between 1 to 80 years were included in our study with the following exclusion criteria. Attention was given to the level of consciousness using Glasgow Coma Scale score to the status of mechanical ventilation and sedation. Visual acuity was assessed by counting fingers when possible. Anterior segment was examined with a torch and a loupe, and the following were noted at every examination. Eyelids were looked for adequacy of lid closure. The following and conjunctival and corneal changes were looked for. Schimmer's test was done when not considered appropriate. Microbiological investigations were done when required. Based on the severity of ocular surface disorders, treatment was given wherein lubricants were prescribed for conjunctival and corneal cirrhosis. For conjunctivitis and keratitis, antibiotics were given along with lubricants. In cases of inadequate lid closure and no conjunctivitis or keratitis, lids were taped with microadhesive tape plaster and lubricants were given. Polythene covers were used as goggles along with antibiotics and lubricants in cases of inadequate lid closure with exposure keratitis. Daily cleaning regimen was advised in all. Patients were followed up till they discharged from the ICUs and 1 month later on. The various predictors of OSDs assessed in our study include Glasgow Coma Scale score, ventilatory status and sedation, adequacy of lid closure, and presence of major systemic illness. The strength of their association was analyzed statistically. 32.5% of our patients had ocular surface disorders. These are the conjunctival changes and corneal changes noted in our patients. This table concludes that patients with a lower GCS score had a higher incidence of ocular surface disorder, probability being significant. Patients on ventilators in our study had a higher incidence of ocular surface disorders with significant p-value. In our study, patients with inadequate lid closure were significantly associated with the development of ocular surface disorders. The presence of any systemic illness like diabetes and hypertension was significantly associated with the development of ocular surface disorders in our study. Coming to discussion, the conventional methods of treatment of exposure keratitis in ICU patients were pad and bandage and lid taping. But both these would create an ideal environment for bacterial multiplication, which can convert a simple bacterial defect into an ulcer. These are the polythene goggles used in our study. These are actually used by surgeons while attending at-risk cases in order to avoid spillage of contents into their eyes. These polythene goggles, in addition to their protective effect, would also help to assess the ocular movements and pupillary reactions through them as these are transparent. It also helps the physician to assess the patient's recovery from coma by observing the lid movements. To conclude, the conclusions of our study are ocular surface disorders are common in ICU patients, most frequently encountered being conjunctivitis and exposure keratitis. These occur more commonly in patients with inadequate lid closure, in mechanically ventilated and sedated patients, those with low levels of consciousness and with severe systemic illness. When managed promptly, this can be easily cured by simple and effective techniques like taping of the lids and use of polythene goggles. Use of polythene covers over the eyes by minimizing the operation, they reduce the risk of dryness, they are simple to apply and easy to maintain. It is possible to assess the anterior segment and pupillary reactions through them. It helps the physician to assess the patient's recovery status from coma. These are non-expensive and easy to manufacture. Other conditions where these can be used include Bell's palsy and any other lobectomic cases. We would suggest refinements that by providing a space for saline soaked cotton if possible inside these goggles, would further help by providing a more moist environment.